pathology of, it's a makeup class, I believe. And we are looking at pathology of the lower female genital tract, which includes vulvovagina and the cervix. You will note from the presentation as we go along that most of the time we'll spend on the cervix. That's really the most important part of this lower female genital tract. So, yeah, diseases of the vulva. Not much. I'll not spend too much time on this, partly because especially the first two tend to be lesions that you see in clinical practice rather than pathology practice. So we will rarely get material for congenital lesions or inflammatory lesions, which are basically seen in a busy gynae clinical practice. I'll spend a little bit more time on epidermal dystrophies, cysts, and tumors. So genital infections, I think this has been largely covered in your microbiology lectures. So it's just really a mention for the sake of completion. These are common, and a large variety of microorganisms cause significant morbidity, but fortunately no serious sequelae. And these include Candida, Trichomonas, and Gardnerella vaginalis. I'm sure you were told that gonorrhea and chlamydia are some of the major causes of infertility, so they're important in clinical practice. Mycoplasma has been attributed to be a cause of spontaneous abortions. So for women with bad obstetric history or recurrent abortions, then this is a microorganism that is important in that space. Genital urinary disease, a common cause is herpes, group of viruses, but of course there are others. And then for us in pathology, HPV is probably one of the most important infections. So let's look at the non-neoplastic lesions of the vulva. These have common presentation, clinical presentation, generally appear as opaque, white, scaly, plaque-like mucosal thickenings. The patient will complain of vulvar discomfort and pruritus. And the white lesion or leukoplakia, sorry, there is a typo error there, leukoplakia, which means white. Leuko is white. Leukoplakia. Common causes include vitiligo, which is a generalized skin disease, inflammatory dermatosis, carcinoma in situ, Paget's disease of the vulva, including carcinoma, and a variety of lesions of unknown etiology. So you can see there is a whole variety from all the way from benign diseases all the way to malignancies. And that's why it's important to take a biopsy of any white vulval lesion, no matter how innocuous it looks. It may be a significant pathological lesion. So this is a photograph from Ackerman surgical pathology, just to show the pearly white lesion in the vulva, predominantly in this case involving the labia majora. So the first one of this is the Lycan Sclerosis, which in some literature you'll see it referred to as chronic atrophic vulvitis. The terminology applies to the same lesion. They're most common in postmenopausal women. and they are characterized by atrophy, epidermal atrophy, fibrosis, and scarring. The skin is pale gray or parchment-like, and the labia are atrophic. And because of the fibrosis and scarring, then the introiters may become stenosed over time. Histologically, it's a local disease, so no systemic effects. There is a small risk for carcinoma for this in this entity. So it's an important clinical lesion because of the small risk, up to 4% for carcinoma of the vulva. And this is what it looks like on histology. A thin atrophic epidermis. Note that the rete pegs of the epidermis are attenuated, in fact, some places completely gone. There's some hyperkeratosis on the surface, a thick layer of keratin, and the dermis is replaced by fibrous connective tissue, and there's a fairly brisk inflammatory infiltrate predominantly around the small blood vessels. Okay, so that's why it's an atrophic, a chronic atrophic vulvitis. The second lesion in this group of epidermal dystrophies is squamous hypoplasia. And as the name suggests, it's characterized by squamous hypoplasia and hyperkeratosis, very similar to lichen sclerosis. But there is increased mitotic activity in all layers. The pathogenesis of this entity is unknown, but generally it's not considered pre-malignant, unlike the lichen sclerosis that we have just looked at. But biopsy is important to distinguish this entity from other malignant white lesions. And here, this is what it looks like. You can see marked epidermal hyperplasia, so it's thickened, exaggerated rete pegs, and a very thick layer of keratin, hyperkeratosis. And if we could see this at higher magnification, you'd note that there is increased mitotic activity. The third entity, which now is less of a dystrophy, but pre-neoplastic and neoplastic, is the entity of vulvar intraepithelial neoplasia, and of course, progressing to carcinoma. Carcinoma and pre-malignant lesions of the vulva are uncommon compared to similar lesions in the cervix. About 1/8 of the incidence of CIN, carcinoma in situ of the cervix. Carcinomas or malignant lesions of the vulva account for only 3% of all genital cancers. 2/3 occur in women over the age of 60, so it's a disease of older women, and 85% are squamous cell carcinomas. Majority of vulvar intraepithelial neoplasia are associated with high-risk HPV, and we'll talk about what this means, high-risk HPV. They tend to be multicentric, so rather than one singular lesion, you may have multiple lesions. And when it gets to the grade of carcinoma in situ, then you may see it referred to as Bowen's disease. So Bowen's disease of the vulva is the same as carcinoma in situ of the vulva. 30 to 40%, which is pretty high, may be associated with another primary carcinoma, either in the cervix or the vagina. And stands to reason because they have a common etiology, high-risk HPV infection. The risk for vulvar carcinoma is increased in the immunosuppressed, such as HIV, or those on long-term chemotherapy and other immunosuppressive drugs. And as we have seen, the risk is also increased in those women with lichen sclerosis or chronic atrophic vulvitis. and squamous hypoplasia where there is atypia. So this Vulvowarts, grossly large cauliflower-like lesions. They're not always like this. They may be flat, just minimally raised lesions. But of course, if they are not treated, then they can grow to these very large, ugly cauliflower lesions that are quite distressing for patients. Histologically, you see this papillary lesion, finger-like projection surfaced by squamous epithelium with varying degrees of atypia. At higher magnification, you can see the thickened squamous epithelium, and it's difficult at this power to see mitotic activity. So here we are, a vulvocondyloma or HPV infection, and typically HPV gives rise to this perinuclear halos that we call coilocytes. And you can see on the surface, there's lots of keratinized squamous epithelium. When it becomes carcinoma in situ, similar changes, hyperkeratosis on the surface, markedly thickened squamous epithelium, lots of mitotic activity, abnormal mitosis, but luckily it's still contained in this particular image, contained by the basement membrane, and that's why we refer to it as carcinoma in situ. Then Paget's disease of the vulva, also referred to as extramammary Paget's disease, because there is an equivalent lesion in the breast, as we saw last time. So you have this large malignant cells within the epidermis, either singular or in clusters. And typically, there is an underlying ductocarcinoma in the subepithelial area. Okay, so this is a typical picture of Paget's disease of the vulva, large malignant cells within the epithelium. And this is a photomicrograph, again from Ackermann surgical pathology, an ulcerated tumor involving the labia, predominantly labia minora, and the clitoris. It's ulcerated and bleeding. It's a typical presentation. And again, labia minora and clitoris. And in general, tends to be well-differentiated keratinizing squamous cell carcinoma. And here in this histological section, you can see the keratin pulse and nests of infiltrating malignant cells. So we leave the vulva behind, not, as I said earlier, not of much interest to the pathology. We don't see much material from the vulva, only rarely. Actually, interesting, towards the end of last year, in 1 week, I think I saw 3 or 4 carcinomas of the vulva, and yet I hadn't seen any throughout the year, so that was interesting. So that's kind of the statistics that we see. You'll see 5, 6, 8 carcinomas of the cervix in a week, not see one of the vulva. So vulval carcinomas are rare. So it was unusual. I made a note. It was unusual to see 3 or 4 cases in 1 week of carcinoma of the vulva. So let's look at diseases of the vagina. And again, there are a variety of congenital lesions, which I'll not go into. You'll cover that in your gynecology. A variety of cysts, inflammatory lesions, which is the commonest cause of morbidity, but fortunately, they're insignificant in terms of mortality, hardly ever. But more important from the pathology point of view is vulvar intraepithelial lesions of the vagina, not vulvar, vaginal intraepithelial lesions, sorry. or neoplasia, and carcinomas of the vagina are extremely rare, very, very rare. If you see one in the vagina, you must exclude carcinoma of the cervix by extension, carcinoma of the vulva, and extension from the either bladder anteriorly or the rectum posteriorly. So it's really by exclusion. We must show that it is primary in the vagina and not an extension from somewhere else. That's how rare it is. So I'll cover really the story of carcinomas of the lower genital tract mirror the story of HPV. So that's why this slide is entitled The Story of HPV and Cervical, and I probably should have added vulvovaginal neoplasia because they have a common etiology. So the presence of warts and papillomas has been known since prehistoric times, so it's nothing new in terms of history of disease. But the infectious nature was only recognized at the turn of the century. You may ask which century, the 20th century. And molecular analysis in the 70s and 1970s and 1980s established that papillomaviruses are the major cause of warts, genital warts, and papillomas. So you can see I have some references there from 1907 and 1898 for your interest, those who are interested in medical history. So what are human papillomaviruses? These are DNA HPV viruses, and they've consistently been found in cervical cancers worldwide, not just in one place, but in all places globally. And transcription of specific viral genes of HPV, particularly E6 and E7, have been found to be expressed virtually in all cancers. And this is why it was established in beautiful papers in Woolboomers and group established that the presence of these specific viral genes in all cervical cancers from a variety of material from around the world, and showed that these two genes have the ability to immortalize human anogenital epithelial cells and to transform them to malignant cells. These two genes are also essential for maintenance of the malignant phenotype of squamous cancer cells. So let's look at briefly the natural history of HPV infection. So HPV infection is, they say, as common as a common cold. So it's one of the commonest viral infections in humans. They are found ubiquitously in the skin and mucosal lining, and the mucosal HPVs are sexually transmitted. So in fact, HPV is the most frequent sexually transmitted infection. High detection rates in sexually active men and women, and it's not detected in virgins. So that's why we know that it correlates with human sexual behavior. So the risk factors for acquisition of HPV infection include early age at first sexual intercourse, multiple sexual partners, contact with high-risk men. And high-risk men, for definition in this sense, are those men who have multiple sexual partners. They have a history of HPV genital disease, and whose partners, if they have any partner who has died of cancer of the cervix or lower female genital tract cancer. So those are high-risk men for definition. Protective risk factors or factors that reduce risk of acquisition of HPV include consistent condom use and male circumcision. There's a lot of literature to support these two entities, consistent condom use and male circumcision. Incidentally, on the African continent, and there's literature to support this, that condom use is very low, okay? Studies that we have done here have shown that this is consistent, not one-off here and there, but consistent condom use is less than 5%. Even during the HIV pandemic, men just didn't use condoms. They didn't perceive the importance of consistent condom use in preventing disease. Yeah, they may have thought it was important as a family planning method, but not in disease prevention. And there are some elegant studies done here in Kenya and in Kisumu by the late Dinya Chola et al. To show the importance of male circumcision, not just in HIV prevention, but also in risk reduction for HPV acquisition. Types, the reason why we don't say one singular HPV virus, it's viruses, is because more than 100 types have been characterized, and about 40 types infect the genital tract. Phylogenetically, genital HPVs belong to the alpha genus, and there are those others that are associated with cutaneous epidermal dysplasia, verruciformis, which belong to the beta genus. It looks like I didn't have, I thought I had the family tree, but if I don't have it, then I'll insert it and share, okay? So let's go back. Okay. So what about HPV infection and the relationship with cancer? This is an old slide, but the figures are generally the same. They haven't changed much in terms of statistics. And you can see the table is divided into developed and developing countries because the statistics for cancers are different in those two groups of countries. But nevertheless, for cancer of the cervix, 100% of all cancers of the cervix are attributable to HPV. That's equivalent of this now must be close to 100,000 cases, total cases, and all of them would be attributable to HPV. And cancers of the cervix globally in developed countries account for almost 2%. But for developing countries, this is a whopping 7%. So it goes up by almost 4 times. Penile cancers, HPV is attributable to 40% of penile cancers globally. Vulvovagina, 40%. Anal, 90% of anal cancers are attributable to HPV. Oral cancers and oropharyngeal, they vary from 3 to 12%. And you can see when you put all the sites together, the total number of cases globally associated with HPV are in excess of 5 million in developing countries and close to 6 million in developed countries and 6 million in developing countries. So HPV globally is responsible for close to 8% of all cancers. So a single group of infectious viruses is attributable to this huge number of 8% of global cancers are attributable to this group of viruses. So that is an important, so if you don't take anything else home, this is a figure to remember, that HPV infection is attributable or is responsible for close to 8% of all global cancers. Then when we look at specific sites and a sampling of cervical cancers from around the world, almost 3,000 cases, we can see that HPV type 16 singularly was responsible for 57%, 16%, then 45, 31, progressively less, and then other types that are yet to be identified. When you put it HPV-X, it means it hasn't been molecularly characterized. And some of this, of course, could be single or multiple infections together. Then when we look at the histological types of carcinoma, we can see, we've already mentioned those figures, and you can see the gray is adenocarcinomas or the glandular type, and type 16 was in this series was responsible for 52%, while it was responsible for almost 59% of all squamous cell carcinomas of the cervix. So in essence, type 16 is the most important, followed by 18, 45, and then the others, okay, 59, 35, 33, and so on. Okay, so if you don't remember any other types, remember 16 and 18, yeah? And then 45 is a minor, okay? So just to sort of coalesce these statistics, 16, 18, and 45, the three of them are responsible for almost 92%. Sorry, there's a doodle flying in my face. 92% of all adenocarcinomas are attributable to these three viruses, and for squamous cell carcinomas, it's about 77%. So what about HPV in other anogenital cancers other than cervical cancers? So we have seen from the table that I showed that cancers of the vagina and the anus resemble cervical cancer with respect to the role of HPV, because HPV DNA has been detected in the majority of these tumors and their precursors. For vaginal cancers is between 64 and 91%, whereas for vaginal intraepithelial neoplasia goes all the way to 100%. All these tumors are HPV DNA positive. For anal carcinomas, HPV DNA was detected in between 88 and 94%. So again, the attributable cause, close to 100%. So HPV is also associated with vulvar and penile cancers, as we have seen. In younger individuals, tumors are usually not of the squamous type, but the basiloid or warty type, and 60 to 90% are positive for HPV, as well as the precursor lesions to these tumors. In older individuals, the tumors generally tend to be the more well-differentiated keratinizing squamous cell carcinomas, and less than 10% are associated with HPV. So younger individuals, more likely to be positive for HPV, and less often squamous, other types, whereas older individuals are less likely to be HPV related. That's really in a nutshell. In all HPV positive anogenital cancers, as we have seen, type 16 is the most common, followed by 18, 31, and 33. What about other cancers from other places, not anogenital cancers? there is a lot of literature to support that HPV is important for particularly head and neck squamous cell carcinomas. Over 60 studies looking at using PCR-based methods. So this sort of meta-analysis studies, you collect studies that have used similar methods so that you're not comparing mangoes and oranges. HPV prevalence of about 26% was established in head and neck squamous cell cancers. That included about 36% in oropharyngeal squamous cell carcinomas, 24% in oral squamous cell carcinomas, and a similar figure in laryngeal squamous cell carcinomas. So you can see that it is HPV important in head and neck cancers. Of this, HPV type 16 accounted for almost 87%. And you can see the figures are high across the board for all head and neck squamous cell carcinomas. And HPV type 18 was the second most common. So both in the anogenital area and in non-anogenital cancers, type 16 consistently was the most important type, followed by type 18. What about skin cancers? HPV family includes cutaneous types as well, not just the mucosal types, as we have seen. And the cutaneous type belong to the genus, the so-called Epiplasia verruciformis types. And they're the ones we say belong to the beta genus. Potentially, they are involved in development of non-melanoma skin cancers, which include squamous cell and basal cell carcinomas. And HPV is identified in up to 50% of these non-melanoma skin cancers, particularly in the immunocompetent populations. But for the immunocompromised, then this figure rises to 90%. There is evidence to suggest that HPV type 5 and type 8 may act as co-carcinogens with UV radiation or immunosuppression in the development of non-melanoma skin cancers. So the synergy may be different in skin cancers compared to the anogenital cancers. HPV has also been established as an important cause of conjunctival cancers. And when HIV came on the scene and there was an increase, a significant increase in conjunctival cancers, then people started looking at it critically and found that HPV is indeed an important factor in conjunctival cancers, particularly in the HIV disease. So HPV has been detected in both benign conditions of the conjunctiva as well as pre-neoplastic and neoplastic lesions. And this was established by finding HPV type 16 and 18 gene expression in both intraepithelial lesions of the conjunctiva. Having said that, squamous cell carcinomas of the conjunctiva are rare, and many are also attributed to or attributed strongly with exposure to solar UV and of course immunosuppression. And where there is immunosuppression, most likely it's HPV. But there's other types. We've looked closely at type 16 and 18, the oncogenic types, but there are also the other non-oncogenic types. HPV type 6 and 11, which were first cloned from genital warts and laryngeal papillomas in the early 80s, gave rise to the terminology of low-risk types. The reason being that they were more likely to be associated with low-grade dysplasia and non-progressive lesions. Whereas the high-risk types, type 16 and 18, 35, 33, 31, 45, and so on, were more likely to be found in premalignant and malignant lesions. And as the Bethesda system of reporting cervical vaginal cytology and histology was adopted, then the low-risk types became associated with low-grade squamous intraepithelial lesions, and the high-risk HPV types became associated with progressive low-grade lesions, high-grade lesions, and carcinomas. So the dual classification, therefore, includes or implies the attributable cause to whether it's low risk or high risk HPV types, as well as progression of clinical disease and the pathology, which is an important concept to understand. So the low risk HPV types, which belong to the alpha genus, include 5 species that are entirely composed of low-risk viruses. Species group 1 include 32 and 42. Species 3, all those, but the important one here is really 10, which includes 6, 11. Those are really the most important in this group. We rarely hear much about 13, 44, 45, and 74, but 6 and 11, as we shall see, are important for human disease. So HPV type 6 and 11 overwhelmingly predominate in genital warts. Close to 100% of all genital warts are attributable to HPV type 6 and 11. But mainly they are associated with benign disease. So genital warts, which can clinically be distressful, but they still remain benign disease. Very, very rarely are they associated with malignant disease. And an important example here is the Bushke Lowenstein tumor, which can involve, we'll see, the anogenital area, malignancy, vulval and penile tumors or carcinomas, thought to be up to 5%. And if there's malignant transformation of recurrent respiratory papillomas, then these types have been implicated. Not always, but now and then. So the incidence of genital warts is associated with behavioral variables. We know that as soon as young girls and boys become sexually active, then they acquire HPV because it's a sexually transmitted infection. The peak rate is 15 to 24 years for girls, and for boys, the peak attack rate is 20 to 29 years. Weak association with cigarette smoking and oral contraceptive use. And it appears that consistent condom use decreases the risk of genital warts by a whopping 60 to 70%. And that's why we really need to encourage condom use, consistent condom use, not just condom use, but consistent condom use. Increased risk of genital warts in HIV infection, with particularly those with low CD4 counts, as low as less than 200. And genital warts, I showed you a picture earlier. They are unsightly, disfiguring, associated with psychological morbidity and feelings of shame. You can imagine everybody wants to look good, whether even in the private areas or parts. So you don't want such disfiguring growths in your genital area. This is an example of the Bushke Lowenstein tumor. This was a male who was practicing sex with men, and you can see a horrible ulcerated cauliflower tumor in the anal region. It's a benign looking histologically, but obviously very distressful clinically, despite multiple resections. It's notoriously a recurrent tumor. And from the story of this patient, I think from the distress, the psychological distress of this non-responsive tumor, even to chemo and radio, he eventually committed suicide. He just couldn't live with this distressing tumor. Sad story. So the low-risk HPV type 6 and 11 are frequently associated with low-grade squamous intraepithelial lesion, that is LSIL. And a look at 55 studies, meta-analysis reported that HPV type 6 was present in about 8.1% of HPV positive low-grade squamous lesions, and type 11 in only about 3% of cases. So they are present, but not in the majority of cases of low-grade squamous intraepithelial lesions. Low-risk HPV types present in recurrent respiratory papillomatosis, which is a rare condition. We don't see it much anymore, but it's characterized by recurrent growth of benign papillomas in the respiratory tract, commonly in the larynx. May have onset in childhood, therefore we abbreviate it to juvenile onset recurrent respiratory papillomatosis, or adult onset, particularly those who practice oral sex. AORRP, adult onset recurrent respiratory papillomatosis. And type 6 and 11, HPV type 6 and 11 are the causative agents in almost all of these cases. There's a good example in the museum, the respiratory tract, of a tiny laryngeal specimen showing good cauliflower lesions, okay, which were obstructing. So have a look at that specimen. In terms of genital disease, type 6 and 11 appear to be the genital tract appears to be the reservoir for type 6 and 11. And for the juvenile onset, RRP, the transmission appears to be from mother to child during the passage of the baby through the infected birth canal. So you will see it in the children born to women with maternal HPV. And if it is present during pregnancy, then there is an overwhelming risk of up to 200-fold for juvenile onset RRP for the infant. And even if it is subclinical disease, the risk is still present. So it doesn't have to be overt clinical disease for the risk to be present for the infant. So Diana, how would you then deliver a woman who has genital warts if she's pregnant and she comes to term and you're the clinician? What would be your choice? Diana Nyanduko, how would you deliver this woman?
I'm guessing CS, cesarean.
Yeah, cesarean section, because you want to reduce the risk. You don't want the baby to pass through the infected birth canal, and therefore you deliver her by cesarean section. So how is HPV infection acquired? We've already mentioned that majority are overwhelmingly sexual contact. So sexual contact, it could be genital-genital, mano-genital, oral-genital. Genital HPV in virgins is rare unless they practice non-penetrative sexual contact. And then, of course, there is a non-sexual contact like mother to newborn or vertical transmission. Fomite, like undergarments or shared towels and so on, we really don't know, a possibility theoretically, but difficult to measure. Transmissibility of HPV, 60% partner-to-partner transmission. For HPV type 16, male-to-female transmission is about 60%. That is higher than HIV or hepatitis B virus, okay, and equivalent to transmission rate of bacterial STIs. So you can see it's highly transmissible, up to 60%. Factors that affect persistence, HPV infection and progression. A HPV type is important. So if you have 16 and 18, then persistence of HPV infection and progression to significant pathology lesions is higher than other types. Viral load, there is inconsistent evidence that viral load of HPV is important in terms of persistence of infection and progression. Then, of course, the state of the virus, whether there is viral integration, is also important in terms of persistence and progression. This is viral integration into the host genome. Clearance of infection, median period of clearance of HPV infection is about 8 months. It's longer for high-risk types. So, for example, it will be lower for type 6 and 11, but higher for 16 and 18. But majority, more than 90%, will have cleared the infection by 24 months. This was actually established by following college students from when they come in, they have no infection, they become sexually active, acquire HPV infection, and how long it takes for them to clear the infection. Some very elegant studies. So now we come to cervical intraepithelial neoplasia, or CIN, which is really the most important story of HPV. CIN represents a continuum of morphologic changes with relatively indistinct boundaries. So you can't say low grade stops here and the high grade lesion begins here, okay, because it's a biological continuum. And CIN, cervical intraepithelial neoplasia, precedes majority of cervical cancers by as many as 20 years. It could be 5 years or less, particularly in the immunosuppressed, but in immunocompetent people, it's been shown by looking at historical material that it could be as many as 20 years from when they first have HPV disease infection up to the time they present with a CIN lesion. Many will not invariably progress. Some, in fact, will spontaneously regress. So that's really the natural history of HPV infection and CIN. That it's not always a progressive lesion, and some do spontaneously regress. However, the higher grade lesions have a higher risk of progression, and the low grade squamous intraepithelial lesions rarely progress. Some will, majority will spontaneously regress, even without treatment. So this is a cartoon representation of natural history of CIN, so that's the virus getting into the normal epithelium. When a young woman becomes sexually active, then it infects and integrates into the basal cells, and then becomes a progressive infection. So more and more cells become infected, and more cells change in the epithelium. It may become a persistent infection, and more cells become not only infected, but they change both morphologically as well as molecular. They become immortalized. Remember, the high-risk HPV types have ability to immortalize the squamous cells. In the natural scheme of things, as cells move from the basal cells and grow towards the surface, they grow towards the surface and die. Yeah? And then they are replaced by the basal cells, which are the dividing cells. But HPV immortalizes these cells and therefore eventually become autonomous and malignant. Okay, so we can grade the changes from when you have just the lower layers of the epithelium change, that's a low-grade lesion. When you have more than a third or cells that morphologically show changes and they occupy more than 1/3, then that's a high-grade lesion. And then when it's a involvement of the full thickness of the epithelium, then that's a CIN3 lesion or a high-grade lesion or carcinoma in situ. Okay. Then when it breaches the basement membrane, then it's an invasive carcinoma of the cervix. Then this process takes, here may take anywhere from a few months to years and decades, a couple of decades, as we have seen. But there are many factors that determine how rapid this progression will be, okay, such as immunosuppression and so on, and HPV types. So majority will regress and the epithelium will recover when the immune system gets rid of the virus. So up to 90% of HPV infections, even with epithelial changes, will regress. And only a small percentage will progress. In fact, it's thought that even a small percentage of invasive carcinoma, not that you would allow a patient with a carcinoma to hang around waiting for regression, but that they do regress, looking at historical materials, okay? And it's this period between infection and carcinoma in situ. That's the period you want to screen so that you can you can intervene. Okay, you can treat the patient so that she doesn't progress into invasive cancer. Majority of those women who progress to invasive cancer are the ones who've never had a pap smear or screening in their lifetime. Okay, but once you have a high-grade lesion and invasive disease, then it's time for treatment. Okay, so before that, the screening period, yeah, and after that, you find a lesion, you screen. If she has a high-grade lesion or more or higher, then it's treatment. Okay, so primary prevention is preventing women becoming infected with HPV, and primary prevention is HPV vaccines. Secondary prevention is secondary prevention is screening and treatment of pre-malignant lesion and early invasive disease. Okay, so I think, again, this is one of the charts that if you don't remember anything else about this lecture, please remember this. Yeah, this concepts about the natural history of disease and where it is important for primary prevention, for screening, and for treatment. Very, very important. Okay, if you don't remember anything else from my lecture today, remember this chart and the explanation. Okay, so let's look at invasive squamous cell carcinoma of the cervix. This may occur at any age from the second decade to senility. When I started my work in CS cervix and HIV and HPV, I would be horrified to see a 20-something-year-old with cancer of the cervix. But of course, most likely, yeah, she was HIV positive. Okay. Just give me a second, class, 2 minutes. Sorry, I'm back. So Yeah, I was saying how initially I used to be horrified to see a 20-something-year-old with invasive stage 3, stage 4 cancer of the cervix. But that was in the context of HIV infection. But in the general population, the peak incidence of cancer of the cervix is 40 to 45 years. In fact, from studies done by people in OBGYN in our department, in our university, the peak was about 42 years, which is 10 years later than for CIN. So women with the peak for women with CIN is about 32 years. So you can see that it progresses. It takes about 10 years to progress to invasive disease. So the risk factors for invasive squamous cell carcinoma is early age at first intercourse. Again, the risk of HPV infection is very high at that age, multiple sexual partners, and the high-risk male partner with multiple previous sexual partners, and so on, the way we defined it, a high-risk male. Okay, minor risk factors include oral contraceptive pill, cigarette smoking, high parity, family history. High parity, often when I see, I look at the history of women whose material I'm looking at under the microscope, you'll see many, the parity is 8 children, 10, 12 children. So yeah, parity definitely is a risk factor. Family history thought to be a minor risk factor. Associated genital infections, this has always been a debate. I think the jury is still out there. And of course, lack of circumcision. We saw earlier that circumcision of the male partner has a somewhat protective role. Most important risk factors, of course, is persistent infection with high-risk HPV types, particularly type 16, 18 being the most important, then 31, 33, 45, and 56. Those are the 6 most important, with 16 and 18 being the very top of the list. And this is linked to the ability of carcinogenesis and is linked specifically to viral oncogenes E6 and E7. And current literature states that HPV is a necessary cause of cancer of the cervix. So if you don't have HPV infection, then you're unlikely to get cancer of the cervix. That's basically what that statement means, a necessary cause. So it has to be in the equation. The mere presence of HPV may not lead to cancer of the cervix, but for those with cancer of the cervix, HPV is part of the equation. Rarely low-risk HPV type 6, 11, 42, and others associated with invasive disease, as we have seen. And I gave you the example of the Lowenstein, Bushke Lowenstein tumor as an example. Morphology of the cervical cancer. 3 distinct growth patterns. It may be a fungating or exophytic mass, ulcerating, infiltrating tumor, microscopically, majority, more than 95%, are squamous cell carcinomas. They may be well-differentiated, keratinizing tumors, non-differentiated, and undifferentiated. And even very few, we see neuroendocrine carcinomas, but these are very rare. 10 to 25% are glandular type, or have a glandular component, so pure adenocarcinomas or adenosquamous carcinomas or undifferentiated, or the clear cell carcinomas, which are not HPV related, but they are related to diethyl stilbestrol exposure, so a hormonal exposure. Staging, clinical staging of cervical cancer. Stage 0 is when you have CIN disease or in situ disease. Stage 1 is when the cancer is confined to the cervix. You'll do this better when you go into your clinical rotations in gynecology, gyne-oncology. Stage 1, there is stage 1A, 1B, 1A1, 1A2, 1B, and so on. And then stage 2, the cancer extends beyond the cervix, but not to the pelvic wall, involves the vagina, but not the lower 1/3. Then stage 3 extends either into the pelvic wall, and there's no free space when you do a rectal exam between the tumor and the pelvic wall. All the tumor involves the lower 1/3 of vagina. And then for stage 4 disease, the tumor extends beyond the true pelvic wall to the rectum or bladder mucosa and all their distant metastases. So the clinical cause, we've already seen that the disease evolves slowly. By the time a patient is presenting with PV bleeding and discharge and pain, pelvic pain, and so on, then it's late stage disease. So the only early sign of disease is shedding of abnormal cells during screening. Once the disease is invasive, then a patient may present with postcoital bleeding or abnormal vaginal bleeding, foul-smelling fish odor discharge. In fact, they say when a patient walks into the room, you can make the diagnosis by the foul smell discharge, which is really disheartening for the patient or distressing. Okay. I don't know how many of you have been to the gyne-oncology ward. You would know what the fish odor, or if you've been to the fish market, the foul fish smell is very distressful. Advanced disease, patient will have obstructive symptoms, either urinary tract symptoms or because of rectal disease, they'll have obstructive lesions. I remember when I was a registrar, there's a patient who came in with through casualty, looking like she was in renal failure. Of course, she was admitted to the medical ward. Then the registrar in the medical ward actually decided to do, because she was in renal failure, decided to do a VE, and the patient has had a frozen pelvis. Her pelvis was just full of tumor involving the lower, the vulvovagina, really filling the entire pelvis with urinary tract obstruction, hydronephrosis, pyelonephritis because of obstructive uropathy, and chronic renal failure. Yeah, and nobody, through the cause of high interaction with the medical personnel, nobody had ever done a vaginal exam. Screening. So in terms of, so that's clinical cause, very distressing disease. Unfortunately, majority of our patients come in stage 3 and stage 4 disease. We don't have a good culture of preventive medicine by annual screening. Our screening rate, I think it has improved to 15%, but for a long time, it was less than 5% of women and had an annual pap smear or even a pap smear in their lifetime. I think the figures from MOH show that this has increased maybe to about 15%, but it's still very, very low. And that's why majority in stage 4 disease. So screening really, by whatever means, whether it's just somebody looking at the cervix, a speculum exam, a pap smear or a HPV test should begin when a woman becomes sexually active. The MOH cancer screening guidelines, they tell you how often to screen. But rule of thumb is 2 normal consecutive annual screens, then you screen after 3 years. If you have 2 normal consecutive screens, 3 years apart, then you screen after 5 years, then 10 years until the age of 60, after which if she has had normal annual screens, then she can basically get off the program. Annual screens, that you tell a woman come next year in January, are only justified for those who are considered high risk. For example, if she has had a previous abnormal pap smear or abnormal HPV test, or she has been treated for a cervical lesion or a vulvovaginal HPV related lesion, then she's in the high risk group. Okay, so don't do annual screens, 6-month screen like I see some people doing. That's a waste of time. We've seen that HPV disease progresses very slowly for majority of women. So unless she's high risk, you don't need biannual 3-monthly screens. That shows that you don't understand the natural history of this disease. Okay, so please don't. I don't want you to get into that bad practice of annual pap smear or HPV screens. Okay, it's a waste of money. Everybody can save money, and it doesn't make sense scientifically to screen annually unless she's high risk. HIV positive women are also high risk, so those should be screened annually. Screening by human papillomavirus test. These are still expensive, but they're available and they're important tools for triage. So if a woman takes a HPV test and she's positive, then she can have a pap smear. Okay. Otherwise, if you have a negative HPV test, then you don't need a pap smear, because without HPV, then there will be no cervical morphologic changes. Yeah? So that's really the scientific basis. Only those with high-risk HPV types then will have cytology and follow-up. Yeah? So now those move to the high-risk categories. Okay. If a woman has a high-risk HPV test and a CIN confirmed on colposcopy, and then she has colposcopy and biopsy. Yeah, because again, not all women who will have a high-risk HPV infection will have a significant lesion. So that woman on colposcopy may just have a low-grade lesion, which you can opt to treat or just follow up. But high-grade lesions, CIN2 or higher, must be treated, because this is a woman who is at risk of progression. Okay, so treatment for CIN lesion, for low-grade squamous intraepithelial lesion, particularly those who you feel are likely to get lost to follow up, then you can do cryotherapy. You simply freeze the epithelium where the lesion is, the cervical mucosa. For high-grade squamous intraepithelial lesions, then you do a loop excision and conization. You just take a cone of the cervix out and send it to pathology. For invasive disease, then that patient goes for staging, and then she may have surgery and or radiotherapy, depending on which is applicable for stage of disease. Prognosis of invasive disease is largely dependent on stage. The 5-year survival rate, which is how we measure survival and prognosis of malignant disease. For stage 1, those are women whose disease is confined to the cervix. Then 5-year survival rate is more than 90% with treatment, of course. Stage 2, 75%. Stage 3, where majority of women come, 35% 5-year survival rate. And for those who have late stage disease, 10 to 15% will be alive at 5 years. And majority will die as a consequence of local invasive disease rather than metastasis. So like the case I gave you, who ended up with a frozen pelvis, a chronic renal disease, obstructive uropathy. She can't pass stool because the rectum is full of disease. Then most likely she'll fall in this category. She had stage 4 disease. So she will probably not die of distal metastasis, but local disease, consequence of local disease, which in her case was chronic renal failure. So some epidemiology, globally, we know that cancer of the cervix is the second commonest cancer among women, affecting, I think this figure has now gone up to probably 500,000, close to 600,000 worldwide, and 80% of this are in developing countries, because we are the ones who don't have screening programs or consistent, reliable screening programs. Most common cause of death, it's cancer of the cervix is the commonest cause of death, cancer death in women in developing countries. And this changes between breast and cervix from year to year. So some years it's cancer of the cervix, some years it's breast. And yet, cancer of the cervix has the best documented effects of prevention by screening, early diagnosis, and treatment for early lesions. So effectiveness of screening, whether it's cytologic or HPV test screening, is important in terms of disease prevention, and the cervix is also easily accessible by colposcopy and for biopsy. So we have all the tools. There's really no need why women should still be dying in the hundreds of thousands from this preventable disease. Plus, of course, we have vaccines. Yeah. So this is a chart from I got quite a while ago from the K&H Medical Records Department, and I need to ask them to give me an updated version. But at that time, if you look at cancer of the cervix, these were their cancer cases documented. Brilliant yellow is cervix, and you can see over this 5-year period, 2000 to 2005, cancer of the cervix was consistently up there. Just some years like 2005, where it came second to breast, which is blue, the light blue, and the red was esophagus. Okay. So it's an important disease in terms of the patients who access cancer care for K&H. The cancer of the cervix is at the top of the list almost all the time across this 5-year period, and probably hasn't changed much. So prevention of cervical cancer, there is secondary prevention by cytologic screening and treatment of early lesions. We still don't have therapeutic vaccines. There are no candidates. I think lots of trials have been done for therapeutic vaccines, but none exist so far. None have been approved. A visual inspection with acetic acid and visual inspection with Lugol's iodine. So you will hear the gyne-oncologist talking about VIA villi. That's visual inspection with acetic acid and with Lugol's iodine, where you paint the cervix with acetic acid, which is table vinegar, and the lesions are white, acetal white lesions, light up, and then they can be biopsied to confirm whether it's a premalignant lesion. And then there's HPV testing. I've already told you how you use HPV testing. It's simple. It can be, there's a self-collection of sample if you don't want to go and have it done. So you can get a self-sampling device, and then you just take it to drop it off at the lab. And if it's positive for high-risk HPV types, then you have a pap smear. And then primary prevention is the prophylactic vaccines, which I will say something about now briefly. Prophylactic vaccines are composed of virus-like particles or VLPs, which incorporate the L1 capsid protein, and that is conjugated with either alum or SO4 adjuvant, developed either in insects or yeast cells. We have actually three now, but these were the initial two vaccines: a quadrivalent vaccine, Gardasil, produced by Merck, which prevents or protects against infection by HPV type 6 and 11, which we said, remember, are the most important for genital warts, and 16 and 18, important for both genital warts, low grade, high grade, and invasive cancer. And then the bivalent Cervix vaccine by GSK, which protects against type 16 and 18. Okay, so those are the two generally available vaccines here in Kenya. A couple of years ago, FDA also approved the non-novalent vaccine, which protects against not just 16 and 18, but some of the others as well, 45, 31, 33, 56, and so on. Non-novalent, and that would basically cover the viruses that are responsible for more than close to 97% of genital neoplasia. So this is, I thought I would show you some histology of a low-grade lesion. This is a squamous coilocytic changes of the surface squamous cells. And the pap smear, what would we see on a pap smear if we were to take a pap smear from a woman with this lesion? So the typical coilocytes, perinuclear halo, very distinctive, and an abnormally large nucleus. This would be a normal nucleus of a superficial squamous cell. You can see that these are larger and darker and abnormal. Okay, so that's how we recognize them on a pap smear. This is a Cin1 lesion similar to the previous one, and you can see there is marked hypoplasia of the, or thickening of the squamous epithelium, and the marked coilocytic changes of the squamous epithelium, but it's confined by the basement membrane. So this is a cone biopsy. It is simply the way it says, it's a cone. You go and take a cone of the cervix, especially if you have a grossly evident lesion like this one. It's ulcerated, it's bleeding, it's causing swelling or bulbous swelling of the cervix. So you do a cone, which is both, it provides material for histology, and it's also therapeutic, because then we are able to tell the surgeon whether the margins are clear of disease and whether the patient is cured. So histologically, the lesion involves the full thickness of the epithelium with abnormal cells. There's no maturation, lots of mitotic figures, loss of polarity. The cells are going in every which way direction, and this would be the equivalent pap smear. This is what we'd see on a pap smear of this lesion. Okay, this squamous cells, intermediate and superficial cells with very large, dark, hyperchromatic nuclei. And a CIN lesion with glandular extension. So the lesion involves the full thickness of the epithelium and dips into the glandular crypts. Okay, so that's how we recognize a glandular extension. This is important because of treatment. You don't want to leave a lesion that has involved the glandular crypts behind, and therefore when we see it, we report it. Okay, so the clinician always wants to know whether there is glandular crypt extension. Invasive disease, you can see this abnormal squamous epithelium on the left. It involves the full thickness of the epithelium, but then there are nests of cells in the subepithelial area with intense inflammatory response. And the equivalent pap smear, you can see small dark cells similar to what you see on the epithelium in the histological section. Small dark abnormal cells that are not maturing, but they're just there malignant. A cone of the cervix, cervical lesion, you can see it's ulcerated, it's exophytic, causing enlargement of the cervix. And on histology, there's keratin pulse, tumor is infiltrating into the subepithelial tissue, obviously an invasive disease, but it's keratinizing. So it's a well-differentiated keratinizing squamous cell carcinoma, which majority, more than 90% of the carcinomas of the cervix are squamous cell carcinomas. And this is an important picture I thought I'd show you from Ackerman surgical pathology to show you a late stage disease. So this is the cervix, the uterus, the body of the uterus, and the cervix has completely been eaten away by this white tumor that extends posteriorly to the space between the vulvovaginal cervical region into the space. Involves the vagina, right all the way down to the lower 1/3 of the vagina, and anteriorly in the psychovaginal space and into the wall of the bladder. You can see the bladder mucosa is nodular with tumor and it's bleeding. So this is late stage disease that extends beyond the cervix into the surrounding adjacent organs. And this would be the pap smear of this lesion. So late stage disease, squamous cell carcinoma of the cervix. So further reading, I think it's important for you to look at the MOH National Screening Guidelines that were published in 2018. These are documents that are reviewed to conform with current clinical practice. So I think this document, I was part of the team that worked on this document. We worked on it throughout most of 2017, and it was published in 2018, January 2018. So it's due for review after the end of this year, 2022. So the MOH will likely be getting a team together again to review what has changed in the science so that the guidelines can be up to date and evidence-based. Then I thought I would put in, there's a lot of material. I thought this paper was interesting because it sort of describes the science that involved the cervical screening, cancer screening at that point. So in terms of the thought process. I think it was good. Sorry, I think there was an error here, but I'll correct it. And then a paper, not too old, 2018, by people in the ministry led by our head of National Cancer Control Program, Dr. Nyangasi, predictors of cervical cancer screening among Kenyan women. And you can see some of the reasons that they found that inform behavior, screening behavior among Kenyan women. And I've told you that it remains pretty low when you compare to other parts of the world. Okay. Then I thought I would throw in as possible as a question, discuss cancer of the cervix under the following subheadings: the risk factors, the natural history, clinical presentation, and prevention. For me, prevention is very important. This is a potentially preventable disease. With all the tools that we have and the scientific knowledge on the natural history of disease, really no woman should be dying from cancer of the cervix. But unfortunately, it's one of the commonest cancers, cause of cancer deaths among Kenyan women. So yeah, there we are. Any questions? It's a long lecture. I apologize.
Recording stopped.
Which of the disease? Okay, any questions, class? You can see, let's see from the chat. How do you test for HPV in non-symptomatic males? They can just go and for a swab. It's the same principle as doing HPV testing in women. Okay. Probability of reinfection is high because human beings are sexually active. So that's a possibility, highly probable, and especially with people who have multiple sexual partners. So again, encourage your patients to be faithful to one partner rather than having multiple sexual partners. Okay. Somebody is saying, interesting, cervical cancer awareness month. Yeah. Usually we do a lot of public lectures during the Cancer Prevention Month, and even in October, which is a Kenyan Cancer Awareness Month, not just breast. So yeah, we do that all the time, but it's important for our students also to know it's an important disease. It's important for your role because you can influence not only your peers, but also the women and men in your lives, being aware that cancer of the cervix is a preventable disease. So nobody really needs to die from this disease. Yes, the vaccine is available for all ages. You can certainly walk into any gynecology office and ask for vaccine, but the government only provides free vaccines for the 9 to 14-year-olds, yeah, as part of primary vaccination. Can male get vaccinated and not female? Yeah, if you are in a faithful relationship, then you can decide which of you get vaccinated. But because you don't know, I would suggest just take care of yourself and get vaccinated yourself. What, 7, 8 years ago, when the vaccine became available in the market, I vaccinated my children, boys, my daughter and my son, and the cousins who were in my house at that time. So everybody got vaccinated, both boys and girls. So for me, that's how important it is. And all my friends who had children at that time, I encouraged them and procured vaccines for them. And since I was in the research group for Mark, then I was able to get them at a good rate at that time, but now they are widely available. You don't have to get tested before getting vaccine. Even if what we call the 9 to 14, we call that primary vaccination, okay, because they're sexually naive. But even for the women and men who are sexually active, they can still get vaccinated in what we call catch-up vaccination. So if you are 16 and you missed the boat of 9 to 14, you can still have your catch-up vaccination, or you're 22 or you're 29, you can still benefit from vaccination and you don't have to get tested before. But if you're sexually active, please get into a regular program so that you know, in terms of your, really after you become sexually active, you now enter the population for screening, but you still benefit from vaccination. Yes. Any other question or comment? The non-valent vaccine, as far as I know, is not available in Kenya, but it is available elsewhere, I think in North America and Europe. But the quadrivalent vaccine by Merck is the one that was approved by the ministry for the primary vaccination program. Okay, so that is what you will find in the MOH clinics that are giving HPV vaccination. But if you want others, then the GSK, then you can access them in private practice. Personally, I favor the quadrivalent vaccine because then it protects against the genital warts as well, the 6 and 11. Yeah. Does it matter if you're a virgin to get vaccinated? You should get vaccinated. That's the right time to get vaccinated because you are sexually naive and therefore you reap maximum benefit from vaccine because these are prophylactic vaccines. Yeah, you should vaccinate before you're exposed to the pathogen, so you reap maximum benefit. Yeah. Any other question? I think I've answered all the questions. Unless there is another one, and before we close. What about lesbian? It really doesn't matter. I mean, the sexual activity is the same, whether you, whatever your sexual orientation is the same. Yeah, they should also get vaccinated. This is a sexually transmitted infection. It doesn't matter whether it's male to female, female to male, male, female to female. It's sexually transmitted. So get vaccinated. Yeah. We finished, I think. You can always send me a text if you have another question or you remember something that you needed me to clarify. I'm happy to do that, okay? So fine. Have a good afternoon. Diseases of the endometrium, was that me who was supposed to cover that or somebody else? Class rep. It seemed to have disappeared. The class rep disappeared. Yeah. So we call it a